Fireworks in the trunk.
Thank you.
Thank you, Pascal. That's a great presentation as always. Couple of questions. What's your current practice with web? Are you using it as much as at the beginning, or have you found maybe some areas that it's really great and some areas where you'd rather not use it as much? What do you think?
So I think I'm mainly using it in ruptured aneurysms, because in those cases where in high grades where you want to avoid clipping acutely and you don't want to put the patient on dual antiplatelet therapy and do Y stenting, or at that time, web would be really a great indication. Like in every device at the beginning, we were using a lot, then it stabilizes, it plateaus. So now it plateaued, right. And I try to avoid using it in small aneurysms also, because in those aneurysms, same thing, risk of dislodgement, risk of rupturing the aneurysm. But otherwise, I think it's a great tool when right. you know how to size and how to choose the patient.
Right, that's great feedback. And what about the new devices? Do you think any particular one of them, obviously you cannot commit, but do you think
I still haven't enrolled in any of them. At Jefferson it takes forever to approve a trial, so we're still in the paperwork stage.
Like everywhere.
Yeah, but from what I'm seeing, both of them are promising tools, and I think we should wait until we see the results. But I think they both will be good tools and a good add-on to what we have already.
That's fantastic. Well, thank you, Pascal. That was certainly an amazing presentation. Thank you for coming to the conference, and I'll see you soon.
All right, thank you.
Take care. All righty, so we will move on. You know what, guys? Actually, we have a couple of minutes to take a short break until we get all our panelists. The last part of our meeting today, and I still see we have a robust representation from everybody. The last part of the meeting today will be a roundtable from all our leaders in the emergency rooms on the majority of our hospitals. I will put everything on a brief break, stay connected, and as we keep getting our panelists all connected, and then we'll start promptly at 3. Hey, Chris, we'll connect at 3.
Sounds good. Can you hear me?
Yes,
All
perfect.
right, great.
All right, it's 3 o'clock. I'm sure everybody's tired. I can see we still have over 200 people participating, which is great. Thank you for sticking with it. We are going to go to our last part of the day after discussing ischemic and hemorrhagic stroke. We wanted to save the best for last and give the forum to the emergency room leaders of our health system to discuss what's in the minds of a lot of the people out there, and that's really what we do with stroke patients. How do we decide where they go? I know EMS providers always have questions. Dr. Rayo, who is the system chair of emergency medicine for our system, and obviously the leader at Good Sam, will lead this roundtable. And we have an exceptional panel of experts to discuss the topics. All right, Chris, I'm going to turn it over to you.
Everybody can hear me okay?
You're good.
So first of all, thanks, Kimon and your team, for having us again. Thanks for putting us on last. So we'll try to keep everybody awake in the late afternoon. This is obviously a topic that's super, super important to all of us in emergency medicine. Obviously, it's stroke is a very critical diagnosis. It's also a topic that's really dynamic and constantly evolving. So it's really important for us to stay on top of our game. In terms of risk management and lawsuits, neurovascular emergencies are one of the highest in the field of emergency medicine. Patient care obviously is what we care about most, but it's a really risky business with stroke, and we're constantly trying to keep updated and trying to improve the care of the stroke patient. There are a lot of challenges in the emergency department. So identification of the stroke patient, obviously, time frames, we're always, pushing to get the treatment to our patients faster. And then, we all work in a variety of different settings. So, resources are different, both locally, regionally, and certainly nationally. So some of the evolving topics in stroke care are systems of care, which we'll touch on a little bit today. And another hot topic is the shared decision making. So, really involving the patient in determining, what type of treatment, where the treatment is going to occur, is another topic that's come up a lot in emergency medicine over the last 12 to 18 months. So without further ado, I'm going to turn it over to some of the chairs at some of our hospitals within Catholic Health. So we're going to have Dr. John Matthew, who's chairman of emergency medicine at St. Joe's, followed by Dr. Bramante, who's chair of emergency medicine at Mercy. And then last but not least, Dr. Jim Ryan, who's chair at St. Catherine's. And they're going to talk about some of these sort of evolving hot topics of stroke care within emergency medicine.
Hey, good afternoon, guys. Can you hear me well? You guys can hear me, okay. I'm going to just share my screen. Can you guys see those slides? Yep, okay. So I know that we've had a lot of talk about ischemic and hemorrhagic stroke. We're coming down to the end of it. So I'm just going to briefly go through some of the discussions as a primary stroke center and some of the disposition issues that we have as being one of the primary stroke centers in our health system. Obviously, we love having Kimon and his team at Good Sam as our comprehensive stroke center. And some of the things that we have been dealing with over the last few years have been helped along by having really a system that has created a network of care for our stroke patients in our communities. So I just wanted to talk briefly about this. I know that many people have put this slide up. You know, one of the biggest issues that we talk about with stroke, obviously, is morbidity, not as much mortality. Obviously, we know the amount of death that we deal with stroke. And, you know, obviously in a year like the last year and a half of dealing with COVID, we still worry about patients post-COVID. This is the same with some of our stroke patients. Obviously, it is the #1 cause of morbidity in patients related to hospitalizations. And this is why we continue to look at treatment and better treatments and quicker treatments in relation to stroke. Pre-hospital settings, I know we have some EMS guys on here. You know, this has been a hot topic of discussion between the city, Long Island, and in larger developing areas of comprehensive stroke centers on where patients should go when they present with stroke. So one of the biggest things that came out of 2019, really, they kept it open between whether you should bypass a primary stroke center to get to a comprehensive stroke center. And in the city, I understand it may make sense with some of these places between a 1-mile radius of a hospital to another, it may take 20 to 30 minutes. Here on the island, you know, what we've shown is get that patient to a primary stroke center first. We have relationships now, and there's every hospital in Long Island has a relationship with the comprehensive stroke center. So you do not want to delay a fibrinolytic therapy for that patient in order to get them to a comprehensive stroke center. We will do what's best for the patient and get them where they need to get to. So obviously, with that in mind, we don't want to skip. Now, there were studies that took a look at this, and I'll get to that, just with EMS and taking a look to see, could they identify large vessel occlusion? And some of the problems with that is, you know, even with some of the scales that they use, the Cincinnati stroke scale is used by a lot of the volunteers. And then you have in the city, they use LAMS, where they are looking for a score of 4 or greater, but they're looking at face, they're looking at arm weakness, and they're looking at hand grasp. And that, again, when you're looking at anterior circulation strokes, yes, that can be helpful to look for large vessel occlusion, but there are also, other than anterior circulation, large vessel occlusion that is in the posterior circulation that can be missed in these patients. So again, with updates that came out, obviously it was discussed earlier, but this is becoming more and more in favor, and we should be seeing this coming through most of our hospitals where we talk about TN case. And there's a couple of different reasons for that. Obviously, you don't have to put a patient on a drip. The medication cost is cheaper, and there may be less cases of bleeding when it comes to non-cerebral bleeding with TN case. Made by the same company, so it doesn't matter, but this is something that we will be seeing in the next year to year and a half. It's already been discussed in our stroke meetings. Kimon, are you using this right now at Good Sam yet, or no?
You mean Tenectaplace?
Yep.
No, so it has to be a system-wide initiative because of the issues with pharmacy, and I'm sure there's going to be some resistance. But you know, the conversation that we were having is mainly that transitioning to Tenectaplace should be either we go full on with Tenectaplace or we stick with Alteplase, because if you have both at the same time, administration is different and it's a time-sensitive intervention. So if one is a bolus, the other one is a bolus and a drip. And
Correct.
There's going to be meta errors and there's going to be a lot of issues. So, but Tenectaplace is better for the endovascular side. There's evidence that revascularization has higher rates with Tenectaplace. And so it would be great. And it's also the fact that it's given as a bolus, so there's no drip to carry on into the angio suite that we are operating on the patient. So that would be great, but we're working on it. There's a lot of meetings on this.
On our side, and I know that we've had some system-wide meetings related to this for a primary stroke center. If I need to get this patient out, giving a bolus of medication and getting him out before they have to go on a drip is very helpful. So there's more to come on this. I think by next year, this should be the standard that we're using. You know, the data has been on this probably since 2017, 18, where they started studying this, and now there's a lot more evidence just looking to support this. So it's just something that we're looking to see. Now, this is where I was talking about the accuracy of diagnosing large vessel occlusion. There are studies out there in the city. They are using this to bypass sometimes primary stroke centers. But here on the island, you want to get that patient to a primary stroke center regardless. You can miss certain things. I mean, we've seen large vessel occlusion. All of us have, you know, where you have a stroke scale score of less. Remember, our stroke scales, they are dominant hemisphere and anterior circulation. favored. So you can miss a lot by looking just at a stroke scale score. And these patients, whether or not they come in, and sometimes you have stroke mimickers, like I even had today. I was clinical this morning with a stroke mimicker that looked like a large vessel occlusion that wasn't. I actually, Kimon, you were speaking when I sent you the patient's MR number to look at the chart.
You gotta do what you gotta do, you know?
So anyway, the point is, what we want to do is get that patient to our centers as soon as possible so we can make decisions that are capable to get those patients to the primary centers that they need to be. Obviously, we know about the changes that we've made to all of our sites, expanding to 24 hours. Now, one of the things I wanted to discuss and that's controversial is our wake-up stroke, and really understanding the difference between MRI diffusion, CT perfusion, CT angios, what we're doing in primary stroke centers. And right now, what we're doing, our primary stroke centers, myself, Rob at Mercy, Jim at St. Catherine's, what we're doing right now is we're doing our non-contrast CT. We want to differentiate between ischemic and hemorrhagic stroke. Then if we find that this patient may have symptoms of a large vessel occlusion, we're doing our CT angios head and neck. Right. So that really that tells me, yes, I have a large vessel occlusion. We haven't really identified, if the time frame is right and we have a good onset of symptoms, that's fine. Get that patient out there. But my brain is different from your brain, different from his brain, and my penumbra may be different here. And I know that what you guys are doing at Good Sam is you are using your perfusion to identify a mismatch there and to see if salvageable brain tissue is there. Now, again, in a center like ours, if they establish themselves in that time frame, I don't think it's a big issue. But as we start talking about the future of stroke care and treating wake-up strokes, then we talk about the dynamics of using MRI diffusion. And I know it's not easy. The time restraints are actually not there. If we're not doing a full MRI, doing a diffusion MRI is not so time restrained. The problem is getting somebody for 24 hours coverage for our MRI, and it's one MRI machine at our sites. We're not doing this here, but I've seen places in this country that they are using MRI diffusion as part of their stroke protocols to treat patients with wake-up stroke. That means large vessel occlusion, a large NIH stroke scale score that woke up with stroke-like symptoms are actually getting TPA or T in case related to getting the appropriate study done. Telespecialists are being used for all of our patients here. COVID-19, I just thought I would touch on this because there was data that came out initially after the first wave, and then we've seen some more recent data. Initially we were seeing, reports from China that 6% of COVID patients present with stroke. Then we had the JAMA article that came out from NYC hospitals. And then there was recently the AHA study that showed it isn't a significant amount of patients that they've showed as compared to a non-COVID, 1% versus 1.3 in COVID studies. But some of the risk factors that they saw in those patients, elderly patients, African-American patients, hypertension, diabetes, high cholesterol. These patients also had concomitant cardiovascular events, higher mortality rates, and these patients didn't end up going home. Obviously, it makes sense if they had COVID and other multi-system issues, they ended up in nursing homes and obviously adding to our morbidity of these patients. So again, something also I wish to discuss, I've talked to Kimon about this a lot, and I know Good Sam has gone live using Viz AI for rapid detection of LVO. It's something I'm honestly looking forward to expanding that program here. And not so much that our radiologists or I call Kimon the minute we get a CT angio so he can take a look at it, but really identifying a system of making things rapidly available so that when I'm looking at it, Kimon is looking at it, my neurointerventionalist, my neurologist, everyone involved in the care of this patient can see what's going on at that time. That cuts down minutes to 10 to 15 minutes on this. And remember, this is an AI software that learns, right? Kimon, can you tell me a little bit more? I would love to discuss this. Just on using the software, it's learning as it goes through.
That's exactly right. So the software is actually pretty cool. What it does is it, obviously like most AI softwares, they identify patterns, and Rapid was used in the clinical trials. All the diffused dawn, it was used to identify large vessel occlusions and/or do the perfusion studies. And so what it does is there's three components, three feedbacks that you get. The first is if there's bleed or not. So you get the head CT, the first thing that pops up is no hemorrhage detected. Obviously, there's a radiologist reading that regardless, and you get a phone call, but at least you have an initial feeling of what's going on, even a couple of minutes before that. And so you can start mixing your TPA or whatever else you're doing. Then the second notification that comes on when you do the CTA is LVO detected, no LVO detected. Again, there's somebody else, a neurointerventionalist, looking at this, but on your end, you can start activating the right processes to move the patient. The third component, if you're engaging into the perfusion software, which is not unreasonable to have, even at the sister hospitals, is that you get an answer about whether there's significant mismatch, and you can see that and quantify that versus, in the past, we would eyeball the perfusion and say, it looks about 30-50% completed. Now you have an exact number of what's completed, what's around. And so you can make a decision about moving the patient, keeping the patient. It's all extremely fast. You can have it come in an app. It's HIPAA compliant, so it can come in your smartwatch. You don't have to be in front of a computer all day, every day, especially if you're a neurointerventionalist and you're not necessarily always waiting in front of a computer. Nobody has to send you images. They all come in a HIPAA compliant way. And so it's really cool that way. And you can communicate via the app also if you want, and you can also, if you want, activate the team via the app. Obviously, we have a lot of mechanisms put in place to make sure that nothing falls through the cracks. So, I would always call the nursing coordinator and they would make sure that they have received positive confirmation that people are coming in the hospital. But you can do all these initial notifications so that people start moving, the team gets activated, and there can be communication. And so it is extremely helpful that way.
Georgie, so you touched on some very interesting points. Before we move on to Dr. Bramante, I just have one question for you. You work at St. Joe's. It's a community hospital, sees about 100 patients per day. So, real bread and butter, busy community ED where you see a lot of stroke patients. What would you say is the biggest challenge you have in managing some of the sicker stroke patients that you have?
So I think some of our primary stuff, thanks, Chris, that's a great question. Some of our primary related stuff, when I'm not sending that patient out, we're still trying to get good at getting our patients door in to door out in 60 minutes. We've gotten telespecialists. Some of the things that have been helpful for us, obviously expanding our stroke protocol to have telespecialists to help us along, right? Sometimes I'm the only doc on, or I have a night doc on who may be dealing with an MI and then gets an acute stroke. Having the telespecialists help us with determination, seeing that patient, even ordering the TPA has been helpful for us. But when it comes to identifying these things, getting the report out to Kimon and getting that patient in and out of our hospitals, that's still a challenge and something we're working on. And that's one of the reasons why I've told Kimon I want to be the first test site for the rapid software over Dr. Bramante and Dr. Ryan. Okay, you choose St. Joe's first. But I think that's one of our issues, obviously here. And then obviously the next discussion, which, I would love to see that we are able to treat some wake-up strokes. But again, in a community hospital where I have limited resources and I may have one MRI machine and there's not a tech on call, getting that patient to an MRI at 4 o'clock in the morning may not be feasible. And it's something that we're going to have to look at as we expand our program and really take a look to treat our patients in our community.
Great. Thank you.
Thanks.
Dr. Bramante, we'll turn it over to you. I think you have to unmute, Rob.
Sorry about that. Guys, on mute for Georgie. So as we discussed through the day, the hub and spoke model seems to really work best, really regionalizing stroke care. Comprehensive and thrombectomy capable centers are highly resource intensive. They require a lot of equipment, a lot of expertise. And getting patients and getting those centers everywhere is just not feasible. So using really the hub and spoke model is the way to go, or the Nucleus model. So we're luckily in Catholic Health. We have 2 centers where we can have interventions done. St. Francis and Good Samaritan, which really cover both ends of the island. And as you see, most of our sites fall really between those 2. St. Joe's mentioned that they send over to Good Sam. We send most of our large vessel occlusions over to St. Francis, but having the option for both sites, especially with higher volumes and during the pandemic, was incredibly helpful. So the questions are bypasses. Dr. Matthew mentioned New York City has gone to a bypass model. People screen in for large vessel occlusion. Mobile stroke units, which exist in Suffolk County at this time, allow for some of that decision making. That's still very early stages in terms of what that will be in the future. In those units, they have CT imaging, angiography imaging, TPA and neurotele specialists available, and can make destination decisions based on imaging results. For most of New York, the plan is still transport to the closest stroke center. Again, most patients are not LVOs. The ones that are LVOs are a smaller percentage of stroke, and the ones that are intervenable LVOs that will benefit from thrombectomy is an even smaller subset of that. So getting the stroke patient, the vast majority of stroke patients, to a stroke center, whichever is closest, is probably still best on Long Island. So what do primary centers do? So we're doing the initial evaluation of care. Really, the key thing is streamlining and developing processes to determine those LVO patients early on. Communication for transfer decisions, and we're going to talk a bit about transfer centers and basically developing those logistics. The comprehensive and thrombectomy cable centers really play a key role in the education and supporting of that mission, basically getting those patients in, identified, and out to definitive care if necessary. So what's been found is that there's really similar care for strokes in the initial care and diagnosis and initial treatment of TPA or connected place, depending on what facility uses, regardless of which center you go to first. So this looks very complex, but it really is basically two branches in the algorithm we use. So basically, is there a CVA possibility? And then looking at other LVO symptoms. So we're using NIH is greater than or equal to 6, aphasia or hemi-neglect. If no, we do a plain CT plus or minus TPA and then deal with it at the primary stroke center with our neurologists. If there's concern for large vessel occlusion, here's the key. Basically send that patient for the CT and CTA at the same time. What we do at our site here at Mercy is we activate the Catholic Health Transfer Center immediately as that patient is being rolled to the CT table, discuss with a neurointerventionalist. They know about the patient, they have the patient story before the images are even up for them to look at. What that also does is it allows for ambulance relocation for that transfer. So our transfer center puts an ambulance en route to our door to be ready to take that patient if it is an LVO to be transferred immediately. What that allows for is for the ED and the neurointerventionalist and the transfer center all in a group call to have concurrent discussion about the case. If it turns out there's no LVO or if the lesion's not intervenable, then continue care at the primary stroke center. If there's something that the neurointerventionalist could help with, then yes, intervention and transfer is basically done immediately. So that really helps that hub and spoke model in getting patients out. So really the main goal is that branch between the primary and Nucleus, the comprehensive stroke center or thrombectomy cable center, to get those patients identified and in or out. To give TPA, to not give TPA before or after, the arguments for giving TPA or connected place are possible recanalization, ease of clot extraction, preventing distal microvascular thrombosis, and then there's the risk of maybe the neurointerventionalist gets in, can't get the clot out, so at least you did something for the patient, giving them some chance. There's potential limited efficacy in large vessels. It can potentially delay transfer, especially with TPA over connected place, because you are potentially setting up a drip and having to get pumps set up. And then, of course, there's the bleeding risk. So one study from about a year ago was out of China, basically showed non-inferiority of endovascular alone. Previous guidance was to give TPA to the eligible patients prior to thrombectomy. There was actually another study I believe I saw an email about yesterday that came out saying that TPA should be considered still. We all know Dawn and Diffuse at this point, and basically this really changed stroke care and really opened up the opportunity for treatment for so many patients that missed it in the past. And then the real question for the future is if the patient is identified as ineligible for TPA in the field, do we bypass a primary stroke center at that point and then get them to what may be their only chance? So the American Heart Association, American Stroke Association of 2018 basically said if there's a positive stroke screen in the field, get them to any primary stroke center or the closest stroke center, regardless of the level, to get IV TPA. So the most important piece of this is really EMS, both getting the patients in, identifying them, more importantly, getting them out if necessary. So transfer centers have really revolutionized this. This is something that we work on pretty much with every case and after every case to improve care and improve timeliness. So it coordinates communication between all parties involved. Again, the primary center, and the neurointerventionalists. They keep active on-call lists and updates. They make sure the ambulances are available to us. More importantly, they effectuate that transport and the care and route of the patient. So what's the role of the hub and the nucleus in all this? So having the extensive resources to help these complex patients, the procedural expertise, individuals with advanced training like Dr. Beckless, basically outreach to the community. Good Sam does a number of community events. More importantly, they provide resources to the primary stroke centers to increase our education, increase staff education, much like this event today, and improve care to our patients. The most important thing is really good communication. I talk to Kimon on a fairly regular basis. I talk to our neurointerventionalists at St. Francis on essentially a weekly basis, and after most transfer cases to review them for quality assurance, for quality review, and to improve and really make those processes as lean as possible for the patients to get to the care they need. So again, the other thing is support role. So it's more than just your ischemic strokes, AVMs, carotid endarterectomies, carotid stenosis, preventing future strokes, treating the causes of strokes, doing cerebral angiograms for patients with symptoms, dealing with carotid and vertebral dissections causing waxing and waning symptoms. So there's a whole list of non-stroke but neurologic emergency conditions that do need to be managed, and this is really what they provide to the primary stroke centers. So as we know, and we've talked about all day, care has been rapidly changing. Over the course of just my career, we went from 3 hours to 4.5 hours to 6 to 12 hours to wake up to 24 hours to who knows where we'll be in another 2 or 3 years. Again, the biggest thing, and for everyone on this, is public awareness, outreach, friends, family, anyone that you can talk to. Basically, if the identification is not made, the rest of this hub smoke, the chain of survival, is really useless. Many families you see to this day are surprised there's a limit to the time of treatment. Most families, as it's fairly new in the medical world, don't know about the expanded treatment windows, the other options. And hopefully in the future, we can expand the window for medical treatment with TPA and really use imaging-based treatment rather than time-based treatment, using CT perfusion, emergent MRIs, as Dr. Matthew discussed, and really assessing, is there viable tissue to save? And as Dr. Rayo mentioned, shared decision-making, education patients about options, having teleneurologists, neurointerventionists talk to the patients about potential options, but having those options don't justify waiting for care. And hopefully in the future, there'll be more ambulance telehealth. This is a project that was done in South Carolina that helped decrease door-to-treatment time by nearly 20 minutes. And basically in the ambulance, the ED, teleneurologist, and the ambulance crew and patient had a 3-way video call where the NIH was performed, where they decided what the plan was going to be, and patients went directly to CT on arrival and already had a plan of what the care was going to be on arrival in the ED. So this really decreased disability and death, and may be the future in terms of determining destination decisions.
So one interesting point, I think, and one positive that may actually come out of COVID is that with all of the talk and newspaper articles saying people with COVID have more strokes, I think that actually is going to improve stroke awareness. Even though people with COVID may not have more strokes, people are more aware of it. And I think we're seeing patients come in who have had COVID recently, et cetera, with symptoms of stroke. So that's one positive that may come out of it. One question I have for you, and this is probably just a prediction or best guess, what do you see regionally here in terms of changes, in terms of EMS destination determination? Do you think things are going to change, and if so, when?
I think at this point for now, things will probably remain the same, getting patients to the closest center, because again, most strokes are not going to be intervenable LVOs. So getting those patients to the closest stroke centers where, again, most of the care, other than the procedure and some of the really complex expertise is available, is really the same. So probably won't change too much. What I see hopefully happening is as EMS expands telehealth, and actually that's probably another benefit of COVID expansion to telehealth, is maybe getting some of those assessments up front, maybe getting that NIH up front, maybe determining and educating EMS eventually to recognize a patient that is not TPA eligible and who has LVO scores, to then get them to a comprehensive center or thrombectomy center rather than to the primary stroke center. Because again, for those patients, that's really the only potential option for them at that point.
Great point. Thank you. Dr. Ryan, you'll close us out. Please, you got to unmute.
Got it. Can you hear me? Hello? Yes? Okay.
Yes, we can.
Okay, wait. I think somebody has to unshare for me to share. It says.
Rob is on sharing. Perfect.
Should be good now.
Good. Okay, can you see my screen?
Not yet.
No? Try again. How about now?
Nope.
Get it?
Nope.
No. Oh, let's try again.
I can run them for you if you want. Up to you.
Okay, let me
Try
see.
again, maybe, and if not, I can do it.
Let's try it one more time.
There you
How's
go.
that? Got it?
Got it.
Good.
Yep, that's it.
All right. All right. Well, good afternoon, everybody. So I'm going to talk a little bit. Let me go back about the challenges in decision making on where to transport our stroke patients. This is a pretty complicated decision based on the data that's out there. So I'm going to try and take you through a lot of data fairly quickly, and then I'll wrap it up at the end, hopefully in a way that makes sense. So you'll all be able to make, hopefully make a reasonable decision based on some of the data I've collected. So, I mean, I think we've talked about this. We'll go through these fairly quickly. LVOs are only about 10 to 15% of strokes. So remember that number. We're going to come back to that a little bit later on. And I think the data is pretty clear that TPA has a poor opening of proximal lesions, and the patients don't have as good an outcome if they have an LVO without endovascular intervention. This is one of the original models, which looks at on the side over here, you have the 10 to 15 LVOs and the non-LVOs, and this is the bypass model to just bypass the primary stroke centers. And then the other model we talked about, the hub and spoke or drip and ship model, where they go to the primary stroke centers first, get TPA and a triage out to the comprehensive stroke centers. So these are the initial two models. Obviously there's a couple of concerns. One, with the bypass model, patients who need TPA might be delayed. Conversely, with the drip and ship model, patients who benefit from thrombectomy will be delayed at the primary stroke centers. One other non-medical concern is the fact that in a lot of these studies, there's 3,000 patients and only 300 get interventions. So the comprehensive stroke center might be overwhelmed if every patient with a stroke-like syndrome gets sent there. It might be an overwhelming number of patients. Okay, I'm sorry. Okay. So what questions do we need to answer before we can determine where the best place for a patient to go is? And there's a couple of questions we need to ask, which one would be, how many patients have an LVO, which goes back to that number we had before, which is 10 to 15%. What is the degree of benefit to the LVO patients? What is the degree of harm to a TPA patient who gets shipped and bypassed a primary stroke center? And then a regional decision is, how much further is a comprehensive stroke center? So the first question, this is just a bunch of studies, and I'm just going to give you a real overview. These are the interventional stroke studies and show the benefits. As you can see, the benefits are fairly dramatic. Sometimes, 20, 25% differences in good outcomes. If you look at the Swift Prime study here, it's 60% versus 35%. So you're looking at, on the right side, the number needed to treat is the number of patients who are treated to benefit one patient. As you can see here, it varies from, in the 7s to the 4 range down here. So there's a wide range here, and just keep these numbers in mind when we get to the next slide. So this is a little bit busy, but what I did was I calculated how many patients would be hurt if a patient never got to, a patient with an LVO never got to a comprehensive stroke center. So the high estimate, I took the lowest number needed to treat and multiplied it by the highest percentage estimate stroke patients, which gives you a 3.75. And conversely, on the next, on a low estimate, if you used a low percentage of LVOs, 10%, and multiplied it times the 7.4, 1 over 7.4 number needed to treat, you get a 1.35. So this gives you the range of patients. So between 1 and 3.5 and 3.75 patients per 100 might do worse off if they don't ever get to a comprehensive stroke center for endovascular therapy. Keep going the wrong way. Okay. So my next slide, I have 2 slides here on the converse, what's the disadvantage if a patient who needs TPA doesn't get it in a prompt manner? And this is a registry study, which if you look at the first column on the left here, it's the door-to-needle time. So I think this was done, I think the comparison groups, this is, I think, a 2014 study. I think the comparison groups like 2010, 2012, before the Get With The Guidelines data came out. So they managed to decrease the door-to-needle time by approximately 10 minutes. And the impact on patients' outcome was here is ambulatory and discharge home. So patients who could walk and patients who didn't go to an assisted living facility. And there was about a 4% difference for those 10 minutes. So for every 10 minutes you delay TPA, you get about 4 patients per 100 are not able to go home and take care of themselves or are not ambulatory. Another large registry study, which shows a similar result. This is like a 58,000 patient study. And for every 15-minute decrease in time from onset, had an 4% increased risk of death, 4% increased risk of intracranial hemorrhage, and 4% increased risk of disability. So you see the numbers at the 10 to 15-minute range are pretty similar in these big studies. So I think these are fairly good numbers. So let's go back to our questions we had before, and we'll try and make sense of this a little bit. How many patients have an LVO? 10 to 15%. What is the benefit? Well, if you do the math like we did a second ago, somewhere between 1 and 3.5% and 3.75% might benefit, would be the outcome benefit from endovascular therapy for these patients. This is assuming that they never ever get endovascular treatment. And we'll get into a little bit more about that in a minute. And then does the TPA delay harm non-LVO patients? And I think from the studies that are out there, it looks like for every 10 to 15 minutes, you have a 4% decrease in good outcomes. And then how much further is the comprehensive stroke center is a regional decision, which could be different depending on what study you're doing. So I did a little graph here, which this graph I had last year. And on this line, it plots if you're a TPA patient, for every 15 minutes, I have a little bit under 4%. What your risk of a bad outcome, of not having a good outcome, is decreased. Over here, this is 3.75%, and this is the 1.35%. So if you look, and that's where the endovascular patients who don't get to the comprehensive stroke center don't do as well. So you look on this graph, the high estimate crosses around 15 minutes, and a low estimate crosses around 6 or 7 minutes. So this is a preliminary estimate from what I can put together from the data. Then, as I said before, the original data I said assumes that the patient never gets to a comprehensive center to get endovascular treatment. So what I did was I pulled together some studies, and I didn't bring all that data here because it would have taken forever to go through this lecture, and I only had 15 minutes. But what most of the studies seem to show is it takes somewhere around 90 minutes, give or take a little bit of time, to get from a primary stroke center to a comprehensive stroke center, so door in, door out. How much does that impact the utility of endovascular therapy? And it seems most studies seem to suggest that 90 minutes decreases effectiveness by 30 to 40%. So what I did on this graph was actually decrease the effectiveness by 50%. So just to even take a lower estimate. And if you look at the data now and you look at the lines, it looks like somewhere around 7 minutes is the high estimate, and somewhere around 3 or 4 minutes is the low estimate. So, based on the data that's out there, it seems, from if you get the large studies come together, and that's why this is so complex, is that this is different for every system, the distance to the stroke centers, and the numbers are very small. So you need a very large study to come up with significant differences. So that begs the next question of why don't we just send patients to the proper stroke center? Why don't we send LVO patients to a comprehensive stroke center and non-LVO stroke patients to a primary stroke center? So can EMS, or can we predict whether it's an LVO based on a neurological examination? So this this is a little bit of a complicated slide for those who haven't seen a lot of statistics, but this is the effectiveness of each of the commonly used scales. And this is what's called an ROC curve. The line here shows what flipping wood coin would do, and this shows the added benefit. So it only adds a little bit of benefit. So in other words, the accuracy of a test is related to the population also. So in other words, if 90% of the patients don't have an LVO, and I said, none of you have an LVO, I'd be right 90% of the time. So it's not just accuracy, but it's how much accuracy do you add to the chance that already exists. And most of the studies have shown that these are not very accurate tests. If anybody knows about likelihood ratios, most have a likelihood ratio of 2, which you need a much higher likelihood ratio to be a good diagnostic test. And this is why. This is a study that looked at, they did angios on all strokes and compared it to the NIHS stroke scale. And if you look, this is a stroke scale and a stroke score on the bottom. And this is just a breakdown of what kind of lesion they had. And if you look, a lot of patients with low scales, stroke scores, had no occlusions. Some had peripheral occlusions, but even with low stroke scales, there were some central occlusions. And if you look as you go out to, let's say, 12s, and I think most of us use a cutoff of 6, but even there, a lot of them, there's no occlusion or peripheral occlusion. So, so as you can see, if the NIHS stroke scale is not a great predictor, it's unlikely we'll have a 4-point scale in the EMS arena that will be very good at predicting who has an LVO. In fact, we had a patient, I think, had a stroke scale of 2 or 3 that we did a CTA on about a month ago that I think we sent to Dr. Beckless and he took care of for us. And they had a large LVO. So, so the stroke scale is not 100%. And that's why I think we're having problems finding an EMS score that's going to work, because our NIHS stroke scale doesn't necessarily tell us 100%. So now I have one recent study. This was just published in June of this year. And this is the first study I was able to find that actually took all patients, not just, it's pretty clear if you take a large vessel occlusion patient and send them to a comprehensive stroke center where you have endovascular therapy, that it'll be effective. This study looked at all patients and what happened. And just one thing to note, this is the patients, this is the description of the patients who were in the study. And it was a group from 2015 and a group from 2018 that were compared, okay? And 11% of patients in this group, I'm sorry, that was the NIHS stroke score. And in the 2018 group, it was 2 points lower. Whereas the endovascular therapy group, it was the same. So this study, what they did was, I think it was done in Czechoslovakia and the Czech Republic, and they used the FAST-EM score to triage patients either to a primary stroke center or a comprehensive stroke center based on the score, on the scale. And what they found, so these are the patients who ended up getting TPA. So as you can see, 2015 is on the left, 2018 is on the right. Onset to needle time, okay, was about the same. Transport time went up by about 8 minutes. But during that time frame, they managed to decrease their door-to-needle time from 44 minutes to 26 minutes. So you would have thought that, you know, based on this, the onset to needle time should have been decreased, but because of transport time, it wasn't. Now this is the, sorry. This is the endovascular group. And what they had the onset to groin time was decreased. Their transport time to the comprehensive center was markedly decreased. But the door to groin time went up, and they're thinking that was because some of the work that had to be done to get the patient ready was done at the primary stroke center before they got there. So, and they also looked at outcomes. So what they found was there's no significant difference in outcomes in the, as far as the Rankin score in the intravenous thrombolytic therapy group. But one caveat to that, they decreased their times for door-to-needle times from 45 to 26 minutes. So there should have been a significant decrease with this decrease. And remember, which we talked about in the last slide, that their initial NIHS stroke scale was higher in the 2015 group. So despite the fact that they were able to significantly improve the door-to-needle time, the patients did not have a better outcome. In the endovascular group, there was a slightly better time, better outcome, but it's not significant. And it was 40% versus 44%. So 44% was in the 2018 group. had a good outcome by the Rankin scale. In the endovascular group, once again, this was not significant. So unfortunately, this doesn't give us any conclusive data, but it suggests that until we find a better way to triage patients or find a better way to ship from one institution to another, it's fairly equivalent. I mean, going to a primary stroke center first seems to work well and seems to be the best standard. So I think some of you guys touched on this already, but who should go directly to a comprehensive stroke center? I think really the groups that should go directly to a comprehensive stroke center are those are the wake-up strokes, because most primary stroke centers don't have the capability of perfusion scans or MRIs with the flare scanning. So a direct transport until we have that capability would probably be best. An LVO greater than 4.5 hours out, we're not TPA candidates. And anybody with a contraindication of TPA, I think would be best served by going to a comprehensive stroke center. And I will leave it there for any questions.
Thanks, Jim. So, I'll just summarize in real briefly. I think from those three talks, it's pretty clear that things are constantly changing, that there's a lot of research that has been done, but that still needs to be done. And I think that's why it's so important that we do conferences like this under Dr. Beckless's leadership to sort of push things forward and make sure that we're at the cutting edge of treatment of stroke. And I'll turn it over to Kimon.
Chris, thank you, Jim. Thank you, John, and thank you, Rob. That was a great roundtable and another great conference for the third year in a row, despite the challenges of not being able to have this in person. The program is running in its fifth year now, and we've been trying to do a lot to educate the community, and certainly this is our flagship event to do that, especially on the medical provider side. I want to thank all the participants, all the folks that gave talks, definitely the folks that listen in and they stuck with us until this time. Couple of housekeeping announcements. The CMEs, everybody's going to get, all the attendees are going to get an email later today and tomorrow with instructions on CMEs, and also the recordings of the conference will be available likely through a YouTube link, which I'm going to share also through these emails that are going to come automatically to all the participants. So if you have any questions in the future, you can reference those. Again, thanks everybody, and we're very much looking forward to more work with all our sister hospitals and Good Sam, obviously, and more conferences to come in the future. Thank you.
All right, thanks.
Bye-bye. Thank you.